Yeah, good morning. So I have with me the team and a complex PCI bifurcation to handle. So Dr. Tomar is going to introduce the case to you and then we go for ahead.
Okay. So this is 62-year-old gentleman. He is hypertensive, diabetic, dyslipidemia, non-smokers, presented with the effort angina, NYHA class 2 for last 6 months on optimum medical therapy. His ECG showed right bundle branch block and there is QS complex in the inferior leads. And his echo showed there is akinesia of mid-posterior wall, mid-vessel inferior wall, ejection fraction around 45%, normal RV function, LA is mildly dilated 4.6, and LV is high normal. There is mild MR and there is mild TR with a pay pressure of 60. These are the echo images.
So we'll straight away take you to the angiogram.
So next, the angiogram, please.
And we see this is the view in LAO caudal. Next, please.
So this is the angiogram. Yes, sir.
So we have a lesion in the bifurcation of LAD and diagonal. Both are significantly big branch. We have a big collateral towards the right. Next. And we have a circumflex and an obtuse marginal which has a tight lesion. Can you go to the today's? So I'll show you the today's pictures and we go ahead with that.
Floor.
So we have done so far. So this is the picture from today's angiogram, and we see a complex bifurcation which we are going to handle, and then we have a obtuse marginal to handle. RCA we're going to leave because of the old infarction. So this has a tight lesion in the diagonal and a big LAD which has a long lesion starting just after the diagonal. So we see there's a big aneurysmal sac in just proximal to these lesions, and this diagonal is reasonably big sized and with a tight ostial lesion which is extending a little bit forward. So our strategy was, next please, is to wire both these branches first. This is a branch to the diagonal. We measured this LAD lesion which is looks little more than little less than 30 millimeters. Next. Following which we've done an IVUS. We'll show you the IVUS run for this.
Yeah, please show the IVUS. Hello?
Oh, yeah. So we are showing you the IVUS run, which is shows this to be a fibrocalcific lesion in the distal part. The vessel size is approximately 3 or little less than 3 distally, and you see a tight stenosis occupying the entire lumen. And then there is a heavy calcium which is seen all along, and as we pull back the vessel size assumes a much bigger shape, and we have a vessel which is almost 3.5 to 4 millimeters just before the diagonal. Then again we have a calcific plaque, and as we enter proximal to the diagonal the vessel becomes really huge. So we have a huge vessel disparity between the LAD and proximal to the diagonal. Following which we have done balloon dilatation to both these branches. Next please. Next. So here we are. This is the final picture after balloon dilatation which I am going to show you now. And I'm planning to do elective double stenting because this diagonal is big and would need to be stented. So I'm going for a double stent here. I'm going to use a mini crush technique with a 2.518 stent on the diagonal and a 3.838 alpine stent on the LAD. So there we are, and now I would look forward to your suggestions and comments.
The national faculty for you. I'm going to just make one comment, if I may. We saw left ventricular function was good, so the decision to leave the dominant right coronary artery alone seems perhaps one that could be challenged. Any comments?
So the patient had an old inferior wall infarction about 8 years back. His posterior inferior territory is akinetic. LV ejection fraction is 45%. So our plan is just to do the LED diagonal and the circumflex. We'll follow him clinically, and if need be, the RCA can be opened. We know that it is totally occluded, but it can be opened. So we will handle that RCA later on. The discussion between bypass surgery and
Sure.
PCI was done with the patient, and he opted to get a PCI, despite being told that his MACE raise may be higher with PCI.
Okay, that's great. Thank you very much. So, from the panel, any comments anyone would like to make about this case?
Dr. Barber, it's Dr. Chu here.
Yeah.
I guess the question in everyone's mind is, with whatever technique that you're going to do, how are you going to deal with the discrepancy in the size of the proximal
Okay.
mid-vessel and the distal?
Right. So I know that and if you see the angiogram very carefully, just after the aneurysm, the size of the vessel is about 4 and looks quite normal on the IVUS. So I'm going to place the stent very carefully just to allow me a pot with a 6 millimeter balloon. So I will use a 4 into 6 millimeter balloon to do a pot at that point. There may be a strut hanging in that dilated portion. I'm not going to really look at it, but I'm going to try to be as optimal as possible. Double mag. As close, if I can do with a 6 millimeter balloon, a pot with 4 millimeter into 6 millimeter balloon, I would be happy doing that. Test.
Eve, any comments about the decision to do a 2-stent technique up front?
It is certainly a case for double stenting, so we know that from the beginning. So the discussion is the way to perform it. I think we can do it using the provisional, and we can do what Charles Young will probably say, that we can do easily, probably with decay crush. So both techniques, you don't have to think that provisional is only for simple. I'm never doing double stenting beginning with the side branch. And when I have to do a double stenting, I know from the beginning that we'll have to implant a stent in the side branch after the main branch. And a pot is, in this technique, a pot is absolutely essential because it opens completely the door toward the side branch. So if you do provisional,
Chalo,
do the pot,
2.580.
absolutely necessary for
2.5.
double stenting technique.
Yeah.
1 minute.
I just wonder if any other panelists wonder
2.5
whether
I
the
think.
choice of stent may be important, whether using a self-expandable stent in these cases with
12,
large discrepancy might take
14.
away some of the issues with the conventional stents.
So we have dilated the diagonal stent
So
first.
it won't be a decay crush.
It's a mini
It will
crush.
be a single kissing crush.
Yes, right.
Mini crush, but single kissing mini crush.
Yeah. No, I will do a final kissing, of course.
So
Two
for a
points
decay
down.
crush, Shaolian will say probably, but for a decay crush, you put the stent in the side branch and you crush with the balloon in the main vessel. And then you come with the second stent. So this, you are probably in 7 French.
Yeah.
7 French.
To do this, you need a 7 French. But a decay crush, you can do with a 6 French.
Right.
I learned well your technique.
Well, for the particular cases, even they are diffuse supply in diagonal, but they also do diagonal diameter stenosis is around 70%, something like that. So I highly suggest to use prominent stent technique for this patient. Although even you use a short stent in diagonal, because there is no very clear distal landing zone for stent is not good. David, what's your suggestion for the patient? 1 stent or 2 stent technique?
Chalo, go.
Well, I'm going to be giving a talk
10.
in a minute, so I'm going to keep my powder dry for
12. 4 into 6 balloon.
So another point is the proximal diameter of VID is very huge, about around 4 and 4.5 millimeter according to the IVUS. So Cochitan is not good. So
Down.
what's the stent diameter?
Can you inject some dye now to see whether you have a passage across with a balloon inflated?
6. Okay, I'll show you. 6. 8.
This will be the problem for you now to oppose the stent proximally.
So I'm going to take 4 millimeter balloon and go high pressure on the proximal part.
The time LED stent 30 or 35?
LED stent was 3.0 because the distal vessel was.
The LED is a 3.0 stent.
Because the distal LED was 3.0, so I couldn't have taken a 3.5. Now I'm going to go with a 4.0 and then with a 4.50.
Which kind of stent you have?
This is Zeiss Alpine.
What stent you have? Sorry?
Zeiss Alpine.
Giant. Yeah. So at 3.0 you can push up to 4. Yeah. More than 4 will be probably difficult.
Double mag hata do.
And if you use the crush technique quite often, do you sometimes use the DK crush to help
Yes, I do.
facilitate crossing again?
Yes.
Or do you, usually do the sort of single step crush?
No, I elected to use a single stent crush in this patient looking at the calcium, that it might impede me getting another stent or getting the balloons or doing the kissing too repeatedly. That's why I saw that calcium and IVUS, and actually I was prepared for a rota also, but my reason to use a single crush was that to avoid difficulties in pushing stents later on. Stent 12, 14, 15, 16, 18, down.
ये 4 है ना?
18, down. So wire.
So is this a 4 balloon?
Yeah.
4 non-compliant.
Non-compliant.
It's a 4 by 6?
6.
10, 12.
12, 14, 16.
I think these 6 millimeter balloons are very useful for the pod technique.
Yeah.
8.
When you don't want
Down.
to involve, for example, a more proximal branch or to do a geographic mix outside the stent.
Test. Wire.
Don't you think that the
System
proximal part is more than 4?
Yeah, it was 4.5 when I was.
Probably more than 4. Yeah.
So I'm going to cross this.
So which wire?
So I have a BMW to cross this. If it doesn't go, then I will think about using a fielder.
And will you take it on a J through the proximal portion
Yes.
down the LAD first
Yes, I will do that.
to make sure you couldn't be behind struts?
Aleocordal. Yeah, I will do that.
As you said, Charles Young, the lesion in the diagonal is very, very long, and there are still a tight lesion distal to the diagonal stent.
Yes, I
but,
saw.
We don't know how to stop here, because if you increase the length of stent, then you increase the risk of stent thrombosis. So maybe the option of doing a provisional with a kiss and looking at what occurs on the side branch maybe was a good option.
So do you need to move to cranial?
Yeah.
To clear sure the ostium are diagonal?
Yeah, I will do that. So आर्योक्रेनियल मुझे एक नया बलून चाहिए 2
2 का balloon दे देना.
2
Cranial. हाँ दे.
So I am going to do a kissing balloon inflation here.
LED के लिए कितना चाहिए? 3 3.5?
4.5.
ठीक है, 4 6 है.
वापस से पिक रहे हैं.
So because this is sort of classic mini crush, you are now going to use the small balloon,
Yeah,
small diameter balloon to open up the strut?
Yes,
or-
I've taken a 2 millimeter balloon to open the struts.
I think it could be useful. I think it could be useful to check where you cross with the side branch wire before inflating balloons
Yeah.
with IVUS.
Okay, we can do that.
Yeah.
Let me
If
see.
you have some difficulty to go through, that means it could be.
Okay. So this cannot be through the side branch. I'm quite certain about it because we can see the way the wires have gone.
Boost कर लो.
I had gone into the LED before I had actually taken this wire
4
down.
वाला balloon दो sister.
So go up 10, 12, 14. So this is a 2O balloon. 16. Down. $16, 18, 20, down. 16, 2.5 balloons. Down. 18,
So this is a 2 balloon.
2O balloon.
2 balloon.
Yes, down.
Do you have stand boost?
Yes, we have. I'll show you the stent boost.
Can you take stand boost at this?
Yeah.
Yes, we have taken. So we'll show you.
उधर दिखा सकते हैं ये वाला?
So you see the crush portion of the stent on the stent boost?
नहीं.
Do you see that?
No.
We don't see
Yeah.
that yet.
Yeah. Now.
Now we see it.
Yeah.
So that's the crush portion of the stent.
Yes, you are inside the lumen in the ostium of the side branch.
Yes. 20. मुझे 2.5 का नया चाहिए. 20. Down. Okay.
2.5.
So it's an important picture because when you are not doing the decay crush, sometimes when you crush the side branch stent with the membrane stent, you are pushing the stent away from the carina. And then if you re-enter the side branch, you can re-enter outside the stent in the side branch. Beautiful pictures have been shown in the past by Yoshi Murasato here. I remember the case.
कितना है 10?
And but here we see clearly that you are inside the stent. So you have the caution you have is to try to cross proximally, but not distally, not close to the carina.
So I'm going to
कितनी
do
length
the
कितनी?
kissing now. Then I will take an avus and then decide about the post dilatations.
करो करो करो.
That's great, thanks. So for your kissing inflation, what sizes and lengths balloons are you taking?
So I have taken a 2.5 into 8 for the diagonal, and I'm taking a 4 into 6, 4 into 8 for the LED. Dochi 4. So by taking these two balloons, I will pull them up till the proximal end of the stent to make it approximately 4.5 to 5. Because just before the diagonal, the stent is big. So let's see what we can do by kissing that with two balloons, 1, 4, 1.1, 2.5. Okay, diagonal 6. Both 6. 6. So I start with low pressure just to make sure the balloons don't slip. Both 10. Both 12. Both down. Check. Small check. So it looks good. Now I'll take an IVUS.
Okay, that's great, thank you. On the panel, would anyone have done individual high-pressure inflations there as well as the KISS?
Yeah, actually, yeah, we usually perform sequential inflation just before kissing balloon inflation. Also, the kissing pattern is very important. I mean, we need to fold side balloon much more into a diagonal. Yeah, to minimize the overlapping length in the main vessel.
So I overlapped it because I wanted to make it
3.0
bigger.
for the LED and 2.5 for diagonal, no more.
I was.
Sister flash color.
So we'll show you the IVUS pictures before we decide about the post dilatation.
And are you taking the IVUS down the diagonal?
Yeah.
I will do that
down
after.
the LED?
I'm taking it on the LED first, and then I will take it down the diagonal. Okay.
Yes.
So this is now pulled back in the LED, yeah?
Yes. Look at the proximal part of the stent. So that looks good. I would take a pull back from the diagonal now.
Yeah, that did look nice. Only a very, very small amount of malapposition in the ectatic segment of the LED.
Yes, right.
Any comments on the
Sister
from
flash
the
color.
panelists about this?
Flush.
Flash. Flash, flash, flash. Okay.
Could you calculate the expansion index according to the IVUS image? I mean, we need only to check the IVUS. We need to calculate something from
Yes,
IVUS
we'll do
image
that.
to guide the
I know,
procedure.
I know. They're doing it, so I don't know if I have enough time on the air with you.
Thank you.
Okay, so we run the IVUS from the diagonal. Can you see it?
Yes.
We can see it. Thank you.
I pushed it again. And there it is at the mouth. This is at the mouth, and there it goes into the LED.
Yeah, it's fine.
Yeah, but I suggest to use a large non-compliant balloon to dilate altitude diagonal again.
I may do that.
You agree?
Yeah, I will go high pressure there because I did 12 atmospheres kissing at that point, so maybe at this point we can do a much higher pressure with 2.5 balloon because the size is not bigger than that.
Yeah, I suggest to use at least 2.75 non-compliant balloon. Osteodiagonal stent will not fully expanded, very small
No,
stent lumen area. Do you agree?
Yes, but the vessel size is also very small. I will take a bigger balloon. Okay, 2.5.
If anyone on the floor has any questions or comments, there are some microphones should you wish to use them.
Now, my question is how many people would go back to this diagonal to dilate, because it is a diseased vessel for sure. Even beyond the stent there is disease. We'll give some nitroglycerin to see how it reacts.
But this diagonal is important. There is a question always in a...
Yeah.
The question,
so,
Kenny.
one point here. I think it's also very important to make sure that we have at least 6, 7, 8 millimeters of stent into the proximal main vessel so that we have room to do the pot. Because if we do the pot within a 3, 4 millimeter stent into the main vessel, then we end up injuring an uncovered area into the main vessel, which may be a reason for anitis for stent restenosis. Also, in that particular case, I think right now it looks like the proximal main vessel stent is malapposed. You have lots of room between the stent and the vessel wall, and that's also an issue here because you may have a condition and environment of stent restenosis. So probably we need to post-dilate more the proximal part, and I think that would be a good case given the anatomical complexity of the stenting, or for a longer and stronger duct, potentially with a tacagal or a prasugal versus clopidogrel for more than 12 months.
Right. So what I have decided is I'm going to...
Very important comment. So according to the IOS image, the
4.5.
proximal stent segment will not completely crush.
4, 6,
So we need to use
6.
more, even 4.5 non-compliant to do pulse
The
again.
4.0 that was used was non-compliant. So you can also use a 4.0 compliant, short compliant balloon, and you can push it up to 4.5.
No. Okay, we are taking a 4.5 compliant balloon for the proximal segment, 4.5 into 6. So as you saw that I had taken the stent a little back to allow for this a good pot to happen.
So again, for the audience, it's very important when you are doing the pot not to do it too proximal, because you are leaving some unopposed cell strut distally. Not to do too distal, because if you do too distal, then you push the carina towards the side branch and you may close it. So it's very important to have the distal marker just proximal to the conical part of the balloon in front of the carina. So we can use, personally, increase the size of my picture. And sometimes I even do a stem boost to be sure that I am in good position.
So I'm going to start from here and go back with this 4.5 balloon. So this is just at the carina, this balloon, and I'm going to start from here and then pull back. 10, 12. This is a 4.5 non-compliant. Down. We'll take another IVUS after that.
तीन का स्टैंड है पे काफी खुल गया है थोड़ा और पीछे ले गए
थोड़ा और पीछे
I think 810 is sufficient.
Okay, 10. Okay, 10. 12.
Okay,
Down. So we're going to take an IVUS, and I guess it will be a pose this time because we've. I think I had missed the proximal strut during my post dilatation, so I have to rewire now. Needle talk.
This one needle talk.
Done. Elio caudal.
David, is the remaining time is 1 minute?
Okay, so maybe.
5 minutes. So you have 5 minutes.
So I'll do the IVUS before we leave you.
Okay. I was ready, Guru.
So you have 1 minute only. So
Okay, so let me
maybe
take an
you have
IVUS.
no time to show us an IVUS.
Epic.
You can show angiographic results for this very good demonstration. please.
Okay, cranial.
Epic cranial.
So
Congratulations.
Eleocranial. I'm quite happy with the proximal position of the stent as on angiography, and I'm quite sure in the IVUS it will be nice.
Yes, so while you're acquiring that, just in case we lose you, just like to say thank you very much from the C3 conference for showing us that challenging case. It was very nicely done.
Thank you.
Sure.
Thank you.
Thank you. Thank you very much.
Thank you.